So by that, I would like to start with my talk. Actually, I was asked also to talk about CGM in shift workers. I'm afraid I could not implement that because of the given short time. So this is actually the outline of the presentation. And I wanted to first have a look because this is primary care diabetes India and primary care diabetes Europe joint session. And I assume that a lot of esteemed colleagues from primary care are attending this session. So I wanted to talk a little bit about the hard job and the dilemma of clinical decision making in general and clinical decision making in specific in primary care, because that is even harder due to a higher level of uncertainty. So first, as I said, there's a prelude where we will talk first about the characteristics of human physiology, and we will see in a minute that they are really not easy to handle. And I also mentioned the chaos theory here to make it a little bit more interesting. And we will talk about how that affects us, as clinicians, and actually what a hard job we're doing every time we are taking a decision together with the patient related to their treatment. So first of all, let us remember that the human body or physiology acts according to the organismic metaphor. So it's not like a machine, it's not mechanistic, it's not instrumental or static, but it is very unique, particular, personal, and dynamic, and displays a lot of variance, and it displays variance in the same person from moment to moment as we speak. So scientifically, it's much harder to predict functions of an organism than it is to predict functions in a mechanism. And thus, prediction in mechanistic models are not complex because most of the time the causality is linear, and you have an equation with only one unknown variable and so on. So things are much more easier in a mechanistic environment. But the funny thing is, in our medical education trains us to avoid uncertainty and to sort of fear uncertainty. So what clinicians or where clinicians most of the time, including myself, we feel very comfortable in is when we have, clear pathways to predict outcomes. But in real life, we all know that is not at all the case. So causation in organismic environments is non-linear, and there's a high level of uncertainty and complexity, which is actually what characterizes clinical decision making. Human physiology is not rigid, it is variable, and it typically would exhibit a non-linear, thus chaotic dynamic. And healthy human physiology, actually, variability is not such a bad thing, because some level of it is healthy or is necessary to be healthy. And healthy physiology has been described a lot of times as organized complexity. For instance, one good example for this paradigm is the heart rate, because if we have reduced complexity, reduced variability, then that means our heart doesn't function properly, which would actually correspond to heart failure. Atrial fibrillation, which we have in a lot of our patients in the elderly population, especially, is a feature of irregular but still not random pattern. And if it's too chaotic, then it is something that is really life-threatening, like ventricular fibrillation. So this example shows us how important the level of variability in this non-linear organismic systems is. Yeah, and clinical decision making, what we do every day, manifold, many times with our patients, and actually for each and every reason for encounter of each patient is a structured, context sensitive, also in itself, very complex and requiring a high load of cognitive performance. And each clinician actually does that based on the patient information, the clinical presentation of the patient, their knowledge and skills, and the evidence-based recommendations, and of course also the preference of their patients. So if you mix all that up, you would have all the sine qua non ingredients for clinical decision making. But as we saw a few minutes ago with the organismic metaphor, clinical decision making is actually characterized by a high level of uncertainty and complexity. It's highly contextual, and it is also related to cognitive biases. For instance, what we do a lot when we do pattern recognition, and we say, that is a heart failure case, then we might anchor and get fixed at our first diagnostic hypothesis and might overlook other things. And one very important thing about clinical decision making, in those of you who are also academicians and involved in education of undergraduate and postgraduate medical students or residents, you would always tell them that iteration makes mastery. So if you do something a lot of times for a long time, in the end, you will become very good at it. And why that happens? Because iteration makes us adaptive. Learning is an adaptive system. So this is all what characterizes clinical decision making, and what is involved in our decision making when we have a patient in front of us and want to come to a decision is we think about risk, we have this level of uncertainty, we have this complexity and chaotic behavior of human physiology. And here I tried to summarize in a little table what this means. Risk actually is something which we use a lot in daily clinical decision making, and this is something where we know the probabilities of in certain circumstances. So this is something which does not move us, which doesn't move us out too much of our comfort zone. Whereas uncertainty is totally, the wolf in the woods, in the fog, unknown or imprecise probabilities, and chaos. It might sound, from daily language that this is the worst level of all it, but it isn't. Actually, chaos is deterministic in the sense that it is predictable in short term because it depends on the baseline status, but because it depends on the baseline status, and this status, as we heard in organismic metaphors or in human physiology, changes as we speak. The longer these variables go together, the more likely they are to change and to diverge. And once it diverges, then of course it will become unpredictable. But chaos is still better than uncertainty, just for noticing that. And complexity is again something we clinicians deal with all the time when we make decisions for our patients, because it has a lot of interacting components. It is adaptive, and there's something more to complexity. It is emergent. It means that during a complex structure, sometimes throughout the process, new variables can be created, which will be then impacting the course of this disease or of the situation. So complexity is adaptive but also emergent, so you can get new variables throughout the process. Yeah, and now coming to primary care, what we in primary care face is actually this famous low prevalence medicine paradigm, which means that we see people who, in epidemiological characteristics, are very similar to the general population. What do I mean by it? Here it says, of course, the classical, definition with the undifferentiated patients and the undifferentiated symptoms and stages of disease. But to give you an example, to talk about the situation in my country, just imagine that you are a doctor, you're a cardiologist working at the outpatient clinic of the Department of Cardiology at a university teaching hospital in Turkey, in Istanbul, let's say, where I come from. And over 50% of the people who come to see you, you would diagnose them with a serious cardiological condition. So if there weren't low prevalence medicine, because the cardiologist in the university hospital practices high prevalence medicine, if there weren't low prevalence medicine, the population of Turkey would be dying out in a few decades. So this so much about low prevalence medicine. And my colleague in the previous talk mentioned how high the prevalence of diabetes is in your country. Very, very similar in my country. I can emphasize a lot with my colleagues here. We are number one in Europe, unfortunately, Turkey, in terms of diabetes prevalence and incidence. Well, anyway, so here I added also this table to summarize again the difference between low and high prevalence medicine. But my point is here, and I pasted it in red, high prevalence medicine has a high level of uncertainty and complexity, meaning that primary care physicians are very good clinicians. They have to be, otherwise they won't be able to help the people they are supposed to provide primary care services for. And as the world population is aging, we are more and more following up in an ambulant manner people, elderly people who have multiple chronic conditions, who are under multiple drug therapies and so on. So this adds to the complexity of decision making. So we are very good in primary care at managing competing risks, because we are not like the guidelines. All the guidelines are wonderful, evidence-based, updated every year and so on, but they are always in silos. They are mono disease oriented, whereas the reality, the patients we see, they have diabetes, they have COPD, they have hypertension, they have osteoarthritis, they have depression, and so on. So do you know any guideline which has evidence-based recommendations for a person who has all these conditions? No. the best, the ADA, the ESD, and the consensus, they are trying to cluster two at the best, maybe three conditions, but three is not the average. The average, unfortunately, in the aging world population is higher, is in your country, in my country. It's a biological fact. It's the same in the UK and in the US. We should also be careful in terms of, quaternary prevention. So deprescribing is very important. I talked about the multiple pharmacotherapeutic agents these multimorbid people are under. And we have all these wonderful evidence-based guidelines, one posher than the other, but all in monomorbid silos. So it's also very, very tricky to combine these evidence-based recommendations. So just to remind us of Ian McWhinney, who is very often called the father of family medicine. He gave a talk at the RCGP, an honorary talk, and there he actually summarized, according to his view, in a very lovely, elegant, philosophical manner, what distinguishes the primary care specialist, the family physician or GP, how they call it in the UK, from other specialists, meaning secondary care specialists like, I don't know, cardiologists, surgeons, and so on. And there, he gave a longer talk. I just took two things which are related to our topic here. He talked about how GPs manage uncertainty and complexity. And there, he actually described six core competences, when describing the characteristics of primary care physician. And the ones he used to talk about complexity were actually the breadth versus the depth of clinical competence. Secondary care specialists are very competent, very knowledgeable, but on a narrow space in detail, whereas in primary care, we are also very knowledgeable, very competent, but on a broad level, and it's the breadth versus the depth. But what does it add to our workload? Because we have variance and breadth, we have a lot more complexity and uncertainty to deal with. And he also talked about the organismic and um, mechanic metaphor. So coming to CGM, my colleague already very elegantly and eloquently talked about the pros and cons of CGM, but what I wanted to bring to your attention here are things like, do I have? Yes. Are things like, can I do this here? No, it doesn't. Anyway, are the things like, for instance, the access and hier mit diesem, yeah. Are the things about equity and access, and it's not all only about the cost. It's also about health literacy and so on. And also something that is not very widely debated, but it is this carbon footprint that all these IT systems actually bring as a load to the environment. But all these wonderful things my colleagues already have talked about, so I won't dwell into these. But just to remember that CGM as a monitoring system creates an ecosystem which delivers complex data about a complex adaptive system. So the CGM data are complex in themselves most of the time. And uncertainty also in CGM data is always present. And even sometimes we can have chaos, although luckily not very often, and very pronounced then and clear in spikes. And when we have chaos, we need to go for safety and stability first. Yeah, and this is a table again because my colleague talked about it. I don't want to dwell too much into it, but this is how uncertainty, complexity, and chaos can come into CGM. And here you see the context uncertainty and also the nonlinear physiology in the human body and multimorbidity, something we deal with actually every day in primary care. And here you see with the cows, first stabilize, then act for optimization. And what we should have a look at in primary care routinely in the metrics is, of course, the time below range for the safety for the hypos, the time in range as the quality indicator of our therapeutic interventions, and the variability coefficient as the stability anchor. My colleague also told us how much better than HbA1c are these metrics because they're real time and they're very granular. And of course, how long the patient is wearing it. So that would be the external validity of our data. And we have to accept also in CGM, although it's a fantastic new tool, the uncertainty, the complexity, and the chaos, but we have to be safe in our mind because we know what to do about it. And now the last thing I want to talk about very briefly is CGM in people without diabetes, in people with pre-diabetes and at risk. And the rationale why this comes up more and more often is that we know that the progression rate to type 2 diabetes is 5 to 10%, and that HbA1c, as mentioned before many times by my colleague, reflects the mean and not the granular dynamics. And we know that postprandial dysglycemia spikes precede hyperglycemia, and those you never catch with HbA1c. So the add-ons again, I'm lucky that my colleague told you everything about it, so I can be brief with that. The add-ons are the higher mean glucose, and we can see the glycemic variability with the coefficient of variance, and we can see exaggerated post-meal spikes and so on. And it could also clinically signal the phenotypes. Is it good as a behavioral tool? A lot of studies, but with people with in people with diabetes, have shown that this biofeedback can be useful to empower the patient. And because it's real time, it's much more convincing, and it reinforces learning on how to manage the disease, and it visualizes, by visualizing the dietary impact, you have the reward mechanism as well as the the danger warning mechanism of it. And we have small studies which have been conducted. Yeah, conducted in people without diabetes, with pre-diabetes, but they are all small in number. Yeah, what should we consider? Actually, for the time being, in people
Ma'am, we are
without
running out of time, so need to continue.
yeah, in people without diabetes, it's not recommended. And although there are expert opinions looking into the future saying it is a good thing also for people at risk. And the conclusion is for selective high risk patients, maybe it might be a good idea, but it's not recommended. And what I want to do before I finish, I would like to invite you all to the primary care diabetes Europe conference. The 18th conference will take place in Istanbul this year in September, and it's my pleasure to invite you all to attend. And we will also have on Saturday a session where Primary Care Diabetes India will present itself.